going on with the scientific session. The next session is about the aortic arch. Please, speakers can come to the podium. And the first speaker is Francesco Schisato from Italy, who is talking about choosing between external and in-branch platforms. Please, Francesco.
Congratulate with Dr. Alonso for this amazing congress, and thank you for the privilege of this presentation. So when we have to deal with the endovascular treatment of the aortic arch, we know that there are several challenges that are related not only to the anatomy, but also to the presence of significant forces, especially when we deal with zone 0, which by disclosure is the topic of this presentation. We have today a variable number of endografts available for the treatment of the aortic arch. I will exclude from the presentation the fenestrated option, and I will focus only on inner and outer branches. We know that regarding the GORE TBE, there are two available options, the one with the 8mm port intended for the LSA, and the one with the 11mm port intended for the nominate artery, but in our region we don't have access yet to the 11mm, so I will focus mainly on these three devices, which are the Nexus endograft with the outer branch, and the Cook and Terumo aortic endograft, which are inner branches. Dealing with the zone 0 endografting, there are several considerations that we have to take into account regarding the clinical setting, the anatomical requirement, of course, and the availability of technical adjuncts, and the time for customization of the endograft. And the answer that I would like to do at the end of this presentation, if it's the inner versus outer branch endograft, that does really matter on the choice on this topic. When we talk about outer branches for the arch, what we really mean is the Nexus endograft. This is a bimodular off-the-shelf endograft with two modules. The main one has an outer branch which is intended for the nominate artery, and then there is another ascending module which is intended for the ascending aorta. You can see here the information for use and the anatomical requirements. The biggest limitation, as for any endograft for the aortic arch, is related to the ascending aorta, which is up to 39mm for this specific endograft. Here's a case of an aortic arch aneurysm that we treated with this device. Of course, there is only one outer branch in this classic configuration, so first you have to do a complete supraortic trunk debranching, and then you go to the endovascular deployment. One of the main characteristics is that the advancement and deployment of the main module is performed after a through-and-through guide wire establishment between the axillary artery on the right side and the femoral artery. And this is very important because it may limit the manipulation and attrition of the device on the aortic arch. Then the second phase is represented by the deployment and the rapid pacing of the ascending module. And this is the final result. This device can be used also for chronic dissection, and here you can see a case where there was a residual dissection after type A repair, and the main issue was that the dissection was extended also at the level of the supraaortic trunks, especially at the level of the right common carotid artery, so the nominate artery was not really a good choice as the inflow source for the debranching. What we decided to do is to use the Nexus bimodular graft using a source for the debranching, the left subclavian artery. As you can see here, this is still deployed after establishment of the through-and-through guide wire system, and then the procedure is completed as usual. So to sum up the advantages of the outer branches, this is an off-the-shelf device which is available also for urgent situation, for example, pseudoaneurysm of the ascending aorta. It has a through and through advancement and deployment which may minimize the aortic arch manipulation, and there is the possibility of targeting the supraortic branches according to the specific patient's anatomy. Regarding inner branches, these are the two main available endografts. The Terumo and the Cook has some slight differences in the design, which lead also to slight different anatomical requirements, with the Terumo aortic endograft that is more liberal in indication for the ascending aorta. They also share the possibility for customized limbs for the supraortic trunks, but in my mind they share also the same limitation, because in both cases they require a 14 French sheath, which may relate to technical limitation, especially when you want to do a percutaneous approach, and they may be also associated to a risk of stroke, which is the main issue in this kind of intervention. So one possible alternative option that we came up in our practice is to use alternative lower profile endografts, such as the VBX Gore, the Viaban, and the Gore excluder limb. This is a case of a Cook arch endograft where you can see the branch for the innominate artery was used. It was the customized version, but then for the left common carotid artery we used a combination of a VBX and a Viaban graft to perform the procedure. Also, the Terumo aortic arch endograft can be used. This is a nice possibility when we have a risk of a slight misalignment compared to the origin of the TSA, because you have this large outlet of the two inner branches. Usually, differently from the presentation that we've seen before, we like to start from the left common carotid, because it has a more straightforward path of the guideway into the right correct tunnel. And then you always have to check on the anterior-posterior view the correct tunnel cannulation. Of course, when you use the two inner branches configuration, the procedure has to be completed by left subclavian artery embolization. So to sum up the advantages, disadvantages of the inner branches, this is a customized solution, and these are the type of endografts that have the larger clinical experience worldwide, and on the other hand, they require a sort of waiting time for the customization. If we want to compare the two platforms, there are not really the right comparison. Regarding hemodynamics, there are only theoretical studies. The only thing I will invite you to consider is that the Nexus endograft has only one branch, so probably you want to consider that, especially in younger patients. Regarding suitability, they have a similar overall suitability, which is no more than 10% in this study, but the curious part is that the specific reasons for anatomical exclusion may differ from one to the other endograft. So if a patient is excluded from one endograft, it is not necessarily excluded for another type of endograft. Regarding the clinical results, we have limited experience with about 30 patients in each independent experience, and similar mortality and stroke rate, but the key concept here is that in any case there is a learning curve, which is especially important to reduce the risk of stroke. And also for the Nexus endograft, we have similar results in the literature. This is our experience. We are lucky because we have access to all the possible devices that I showed during the presentation, and we had a similar stroke rate as compared to the available literature. In the future, combination of outer and inner branches can be helpful to treat a broader spectrum of patients, but there are still unmet needs and open issues. In my mind, the configuration of inner or outer branches is not really what drives the choice of the type of endograft, but what we have to consider is the specific anatomical feasibility, the device availability, and also operator experience and preference. And there are still, in any case, open issues regarding the bridging stance, the profile, the presence of mechanical aortic valve, and also in the long-term results. Thank you.
Thank you very much for the excellent talk, Dr. Esquisato. Next speaker is Dr. Silva, is head of the cardiac surgery department here in the hospital at Asturias.
Muchas gracias, Iván. I will speak in Spanish, so slides is in English. Estos son mis conflictos de intereses y la charla sobre las controversias en la disección aórtica está basada en las nuevas guías que yo creo que siguen la filosofía de este curso. La aorta no es un órgano, por primera vez se trata como un órgano, y los pacientes no solo se tratan segmentos, sino que han de ser estudiados y tratados en su conjunto. La aorta es una enfermedad que afecta a todos los segmentos, no solo a Y las tres controversias que voy a plantear son el tratamiento de la disección no A, no B, cuándo tratarla y cómo, la contraindicación de la cirugía en la disección aórtica por el daño neurológico y la edad como límite en la cirugía. Para esto me basaré en un caso, el recién operado en nuestro centro, que es muy controvertido, puede generar mucha discusión y por eso lo presento, y que actuamos de una forma, digamos, fuera de lo estándar. Lo primero es definir qué es la disección no A, no B. Sabemos que hay un 3 a 10% de disecciones que se originan en el arco aórtico, que ha habido mucha confusión en la clasificación de qué es una disección no A, no B, y que el tratamiento conservador no es bueno. Estos pacientes fallecen por ruptura o malperfusión. Y entonces, la nueva clasificación de la Sociedad Europea yo creo que es muy acertada. Ya no solo se habla de disección sobre tipo A o tipo B, sino incorpora en la clasificación dónde está la puerta principal de entrada y hasta dónde se extiende y además qué tipo de malperfusión tiene. Es una clasificación más funcional, más completa y que nos debe guiar. Y aquí uno de los apartados es la disección no A, no B, aquella que se origina, la puerta de entrada está en el arco aórtico o habitualmente entre el tronco brachiocefálico y la carótida o a veces en el arco aórtico distal y no afecta, puede extenderse retrógradamente al arco, pero no afecta a la aorta ascendente, que algunas clasificaciones hablaban de tipo B retrógrado o no A, no B cuando se afectaba a la aorta ascendente. No, esta clasificación, si está afectada a la aorta ascendente, es una disección tipo A. Por lo tanto, esta clasificación es más funcional, está basada mucho en la imagen y en la localización de la entrada, la extensión y la malperfusión. Es una clasificación, creo, más completa. Además, nosotros tenemos que estratificar el riesgo de las disecciones. Hay dos clasificaciones, la clasificación de Penn en función de la isquemia global o sistémica y un nuevo score específico, el GERADA, para las disecciones aórticas que estratifica en tres grupos de riesgo, bajo, intermedio y alto. Así, con esta nueva clasificación para las disecciones tipo no A, no B, pues establece varias estrategias en función de criterios morfológicos y criterios clínicos y de riesgo. El tratamiento puede ser desde seguimiento hasta tratamiento con cirugía urgente, con frozen elephant trunk o incluso puede, en casos de altísimo riesgo, llevar daría la posibilidad de hacer un procedimiento TEVAR, endovascular. Y vamos con el caso conflictivo, el caso que operamos. Se trata de un paciente de 76 años que nos trasladan de otro hospital en muy mala situación, intubado, en situación de shock cardiogénico, con una insuficiencia aórtica grave en el ecocardiografía y con derrame pericárdico, con situación de shock cardiogénico y con isquemia, malperfusión, un ácido láctico de 7. Y nos llega a la UBI y tenemos que decidir, no tenemos tiempo. Se ha hecho un TAC en su centro de referencia y decidimos meterlo en quirófano, pero estaba en una tensión muy baja, con malperfusión. Este es el escáner que muestra una disección, aunque no tiene reconstrucción 3D, con una probable puerta de entrada en el arco aórtico distal que se extiende a la aorta ascendente, también produciendo insuficiencia aórtica, y en la aorta torácica descendente con oclusión del tronco celíaco, la arteria renal y la mesentérica superior, con signos de isquemia en el hígado, aparte de una mala situación. Por lo tanto, ¿esto es una disección no A, no B? Pues no, según la nueva clasificación, aunque la puerta de entrada está, y luego lo confirmamos en la cirugía, está en el arco, pero se extiende a la aorta ascendente. Por lo tanto, según la nueva clasificación, es una disección tipo A, con entrada en el arco distal y con malperfusión coronaria y visceral, y que se extiende hasta la zona 9. Fíjense cómo en la clasificación de la ATS sería un tipo A, y en la clasificación de la Sociedad de Cirujanos Torácicos o Vasculares sería una disección tipo P. Por lo tanto, sigue habiendo mucha controversia y es importante definir a qué nos enfrentamos. Y siguiendo el algoritmo de la disección tipo A de las nuevas guías, tendríamos que hacer una trompa de elefante congelada de forma emergente. Claro, es un paciente de 76 años con una isquemia y una malperfusión que obviamente eran las 4 de la tarde, hacer una trompa de elefante pues no sería. Y entonces, ¿qué es lo que hicimos? Pues como el paciente estaba chocado, a punto de pararse, le metemos rápido en circulación extracorpórea y resuspendemos la válvula aórtica cambiando la aorta ascendente con un hemiarco, suturamos esa ruptura en el arco con un punto apoyado en parche y decidimos hacer una indicación fuera de guías, que es colocar una prótesis AMDS. El tiempo de parada circulatoria fueron 24 minutos. Esta es la prótesis AMDS. Está claro que los cirujanos cardíacos hemos tratado las disecciones durante mucho tiempo, pero de una forma incompleta. La mayoría de los pacientes siguen con esa disección y esta prótesis lo que trata es de expander la luz verdadera en las disecciones tipo A. El implante es rápido, tiene un teflón alrededor y se sutura la pared de la aorta antes de desplegarse. El despliegue es fácil y progresivamente se va desplegando para cubrir la falsa luz. Digamos que no complica mucho el procedimiento. Esta es la gran ventaja de esta prótesis. Hay varios tamaños. Se ha de medir el diámetro de la aorta entre el tronco brachiocefálico y la arteria carótida y en la aorta torácica descendente a nivel de la bifurcación de la pulmonar. El tamaño elegido en este caso fue una de 55. Este es el despliegue. Aquí ya hemos hecho el recambio de la aorta ascendente y estamos desplegando esta endoprótesis, que es fácil, como decía, y luego se sutura. Bueno, pues ya hemos hablado de la disección no A, no B. Vamos a seguir hablando del caso y ahora la siguiente pregunta es ¿cuándo contraindicar la cirugía por daño neurológico, la disección tipo A? Las guías dicen que en sí la complicación neurológica no debe ser una contraindicación, con un nivel de recomendación 2A B. ¿Por qué? Porque hay estudios que muestran que la incidencia sabemos que es alta, pero que más de la mitad, concretamente un 50-55%, recuperan a pesar de tener un daño neurológico establecido tras la cirugía, y la mortalidad es alta. Y no en el análisis, ni la escala Glasgow, ni la oclusión de los troncos supraórticos es predictor de la recuperación o no tras la cirugía. Lo único que ha mostrado ser predictor es la escala de Rankin, que es una escala de discapacidad en el ictus. Por lo tanto, es hoy en día no debiera estar contraindicado, salvo daño neurológico muy severo o hemorragia, la cirugía por una disección, por un daño neurológico en el seno de la disección tipo A. Y vamos a nuestro paciente. Pues nos las prometíamos muy felices, normaliza el ácido, recupera la función renal y reperfunde. Se quita la malperfusión con esta estrategia. Queda una insuficiencia aórtica grado 2, pero el paciente no despierta bien. Parece que no tiene un daño neurológico claro, pero no despierta claramente. Y se hace un electroencefalograma y se ven signos de anoxia. El TAC muestra ciertos infartos o isquemia subaguda, no aguda, probablemente por la malperfusión en la situación que llegó el paciente. Pero no pudimos evaluarlo porque el paciente llegó intubado y dormido. Por lo tanto, tuvimos que meterlo y es muy difícil en esas circunstancias tener o tomar decisiones. El scan de control, pues esto es lo que observamos. Expansión de la falsa luz, sobre todo en el arco y la aorta torácica descendente, pero seguía algo disecada en el arco. Y esto es lo que mostró el TAC de control. Y el siguiente paso es un paciente de 76 años. ¿Cuál es el límite de la edad en las disecciones tipo A? Esto es un estudio muy interesante que son datos del registro IRAD. Es verdad que es en el año 2014, donde en azul vemos la mortalidad hospitalaria con tratamiento médico y en rojo la mortalidad hospitalaria con tratamiento quirúrgico. Vemos que en función de los rangos de edad, en la mayoría de los pacientes, el tratamiento quirúrgico supera al tratamiento médico, pero a partir de la década de los 80, 85, las curvas se cruzan. Y ahí es donde muchos grupos han establecido el límite en la edad. A partir de los 80 años, sobre todo por el seguimiento a los 6 meses de los pacientes, muchos grupos niegan la cirugía para la disección tipo A. Yo creo que hoy en día hay que hacer una combinación del riesgo o de la situación clínica del paciente con la edad. Y para esto tenemos la escala GERAT, que es una escala de estratificación de riesgo en la disección. Volvamos a nuestro paciente. Le salía un riesgo de 75% y en la clasificación de PEN era un grado BC. Por lo tanto, era un caso muy límite que dentro de unos años probablemente lo solucionemos con terapias menos agresivas o endovasculares. Pero esta fue la situación. Una mortalidad muy elevada, teníamos que tomar una decisión con el paciente. ¿Y cuál ha sido la evolución? Pues sorpresivamente se ha recuperado neurológicamente. El paciente esta semana, porque se operó el día 29 de septiembre, se ha trasladado a la planta, no tiene daño motor y habla y responde ahora, con un posoperatorio, por supuesto, muy prolongado en la UBI. Por lo tanto, sigue habiendo controversias y que tendremos que resolver con la experiencia y con el tiempo. Está claro que yo soy un fan de esta nueva clasificación de la disección aórtica porque aporta más información. Las pruebas de imagen son fundamentales. Hay que estratificar el riesgo del paciente para la toma de decisiones y probablemente en los pacientes añosos con malperfusión habrá que hacer otras estrategias endovasculares. Muchas gracias por la atención.
Thank you, Dr. Silva. Now, Dr. Enrique San Norberto from Hospital Clínico de Valladolid will present to us a new registry for branched endovascular devices. Please.
Okay. First of all, thank you very much for the kind invitation. Thank you, Manolo. I'm so happy to be here again in Oviedo. Congratulations for this type of symposium because obviously we are vascular surgeons, cardiac surgeons, anesthesiologists, but always the focus is based on the patient. We can work together centering the patient. So we wanted to present our preliminary results of the ENDOVARC study. So we are totally agree. The open surgical repair now is the standard of care for aortic aneurysm at dissections, but innovations in endovascular modalities have broadened the treatment regimen for patients unable to tolerate open surgery. So branched branched thoracic endovascular aortic repair, when anatomically feasible, represents a valuable technique and alternative in patients with pathologies involving the aortic arch. Previous studies show encouraging outcomes with low early mortality and acceptable follow-up survival rates. Nowadays, mainly 3 branches devices are marked to treat aortic arch pathologies with proximal landing at zone 0. That is the Nexus, the Roulet branch, and the Scenic arch branch graft. The off-the-shelf Nexus system was the first CE mark approved branch stent graft for the aortic arch, while the Roulet branch, the Scenic Crook, or nowadays the Nexus Duo, tray and custom-made devices mainly. Technical differences are obvious and can influence the occurrence of strokes. The pre-implantation supra-aortic trunks open surgery debranching that requires the Nexus system could be safer, maybe, than the percutaneous access performed for the inner branches endoprothesis. Another key point is the design. Nexus would be more anatomical and different from Roulet, Zenith, and Nexus Duo tray based on the inner branches. And maybe in that inner branches could play a theoretical role in the appearance of strokes during the follow-up. During the previous year, several studies have been published regarding the results of aortic arch endovascular repair with branch endografts, reporting a 30 days mortality between 3 and 10%, disabling strokes between 0 and 7%, and no disabling strokes between 2 and 4%. The anatomical requirements are different for each branched stent graft. For example, the Nexus endograft has the lower profile, that is 20 French. However, the Roulet branch endoprothesis adapts to a greater variety of diameters of the ascending, descending aorta, and brachiocephalic trunk. From January 2022, a study called EndoBarks has been developed in Spain. It's a post-massacre clinical follow-up registry undertaken to evaluate the prevention of death related to aortic arch pathologies when treated by branched stent grafts, that is the Nexus, the Roulet, or the Scenic arch branch graft, with proximal landing at zone 0. The devices were implanted at the discretion of the treating physician, and this multicenter study remains open, and the sponsor is the Vascular Investigation Network of the Spanish Society of Vascular Surgery. Nowadays, 15 hospitals from all over Spain have contributed their experience with the branched endograft for the endovascular treatment of the aortic arch. Nowadays, 36 patients have been included now. The mean age for the total cohort was 72.5 years, with a range from 59 to 84, and 75% were men. Among comorbidities, the most common was hypertension, reported in almost the half of the cases of patients. 19 patients had aneurysm, and 15 of them dissections. Among patients, 12 had a previous history of previous sternotomy, and no cases of connective tissue disorder were observed. 23 patients were managed using the Nexus endograft, 11 patients with Roulet, and 2 patients were treated by Zenith. Previous supra-aortic and trunk revascularization was recurred in 23 patients, and the mean time from supra-aortic trunk revascularization until endograft implantation was 41 days. Almost 5 hours were required for the branched endograft implantation, and you could see into the table the distribution of the bridging stents. Only 2 cases of Nexus required a bridging stents with landing with the brachiocephalic trunk. In 4 cases, an intraoperative endoleak type 1B were observed because they presented a descending thoracic aorta dilatation, planified to be treated in a second step. 2 patients died intraprocedure, one because of left ventricle guide wire perforation, and another one by an aortic rupture. Another 4 died after 7 days, one myocardial infarction, one arrhythmia, another 2 because unknown reasons. And after 8 days, another patient died because of the rupture of a concomitant abdominal aneurysm. So the 30 days technical success defined as successful introduction of the deployment of the branched stent graft system in absence of surgical conversion, mortality, reintervention, unplanned branch vessel occlusion, endoleak, or aortic rupture was 69.5%. After 1 month of follow-up. Nowadays, the total 30-day mortality rate was 19.4%, while strokes were recorded in 9 cases, leading a 16.7% rate of minor strokes. No major stroke were observed. Nowadays, after 1 year of follow-up, the cumulative mortality was 22.2%, one non-related with the aortic procedure death occurred after 6 months of follow-up. No endoleaks, intercomponent separation, loss of device integrity, branch kinking, infection, or creasing of the aneurysm site were observed. The univariate analysis reflects that male gender, aortic dissection, and hypertension were risk factors for mortality after 30 days of follow-up. But after regression analysis, only dissection with an odds ratio of 2.7 and hypertension with an odds ratio of 3.2 were observed as risk factors for mortality. So nowadays, the conclusion, the treatment of aortic arch pathology with branched stem graft system are increasing. This endovascular technique offers a minimally invasive treatment for patients with prohibited risk for open repair, but they are not exempt from the occurrence of life-threatening complications and short-term mortality. Nevertheless, after 1 year of follow-up, their results are very promising. Thank you very much for your attention.
Thank you, Dr. San Norberto. Next speaker is Dominique Fabre from Paris. Will tell us about branched endografts for repair post-type A chronic aortic arch dissections. Please.
Thank you for the opportunity to present back in Oviedo today our experience in branched endografts for type A chronic dissection. For type A dissection with a previous ascending repair, the reference treatment in our center for patients before 65 years old is an open frozen elephant trunk. But the previous ascending repair with a short graft in the ascending is the best proximal sealing zone for an arch device, as you can see here. I will present you our experience with the Cook branched arch endograft, the 3rd and the 4th generation custom-made device with 2 or 3 branches. We made a study a few years ago, and we have now 5 proposed off-the-shelf configuration with 1 or 2 sealing stents, as you can see, that usually fits to all the different anatomies. Regarding type A dissection, when there is a previous ascending repair, most of the time we use only 1 sealing stent, as you can see here on this post-operative CT, and it's enough to treat those patients. We have a multidisciplinary team to decide either to do an open or an endovascular approach. And in complicated case, we often go to the research hybrid room to do some testing before a complex aortic arch endovascular treatment. We have a risk stratification to decide whether we will do an open or an endo approach. And this is the algorithm we use to have. In blue, you have the patients that are good candidates for an endo repair. Young patients are usually discussed for an open approach, and when they are more than 65 years old and they have a suitable anatomy for endo, we go for this approach. So last year we have published our experience with 70 patients with an endovascular treatment of this post-type A aortic arch dissection, with usually 2 or 3 branches, and the permanent stroke rate at 1 year was 2.9%, with a combined mortality and stroke rate in hospital during the postoperative course of 4%, with a technical success of 97%. And this is the CT scan of one of those patients. We then go to a total percutaneous aortic arch approach, and this is the way we do now our replacement. We used to do a pre-closing of the right femoral. We do percutaneous approach of the right axillary with a protection with a 5 French sheath in the right humeral to protect this pre-closing. And then we go for this. This is the operative view, as you can see, everything endo. But one main issue is the bleeding at the level of the axillaries. You can manage with a covered stent at the end through the humeral approach. And with the preloaded wire, with the third generation, the loaded wire is in between the left subclavian and the carotid branch. And the main difficulty is to access this carotid because you have to snare a wire from the branch inside the ascending and then go back with your sheath inside the carotid to access to the carotid. I will show you a small video of this previous cannulation of the left carotid. Quite easy to do the innominate, and also the left subclavian is a retrograde approach, so we use a snare, catch the wire, and then go back inside the carotid branch. Here you can see advancing the sheath with the rotation. Hopefully the ascending is replaced, and then we'll go with the covered stent inside the carotid. Also, due to this quite difficult approach, we change our anatomy of the graft, and now we change also due to the fact that the result of the patency of the left subclavian artery was very good. We change for a retrograde carotid branch, as you can see here. So one antegrade for the innominate, and two retrogrades for the left carotid and left subclavian artery. So a classical innominate approach here, and then you can see that it's much more easy to access to this retrograde branch, advancing the sheath in the left carotid, changing the wire for a stiffer wire, and then advancing. We usually use now Viaban for those branch, even for the carotid and for the left subclavian artery, and sometimes for the innominate. Due to the size of the sheath, we use a Gore device also. This is a post-op result, and same thing for the left subclavian. This is a result of a 3-branch with 2 retrograde, and now we have done 43 arch branch cases with retrograde branch since 2022, 60% for patients with a dissection with a previous ascending repair, with a technical success 100%, no death and no stroke, and 1 type A embolic in a patient. But it's not the only issue for those patients with dissection, because there is still a patent false lumen. So we published this year a paper regarding the management in those patients of the false lumen with those endografts. As you can see now, we add for most of them a candy plug at the distal part of the thoracic graft to completely exclude the false lumen, as you can see here, or in another case here, a candy plug in the distal part. And regarding those candy plug, with the candy plug, we have 40% of patients with a complete remodeling of the false lumen, but the false lumen is still patent when the false lumen is more than 40 millimeter, and no complete remodeling for patients without candy plug in our experience. This is a standard result of 1 patient. And the last thing for those patients is the management of the supra-aortic dissected trunks, because to decrease the level of embolic, we need to sometimes go for a preparation before the endograft, and also to do, as you can see in this 2-branch device, we need to exclude the false lumen in the supra-aortic tones doing a bypass from the right axillary and a carotid to axillary bypass on the left side. And this is the post-operative result for dissected supra-aortic trunks. with a nice exclusion of the false lumen, as you can see here, just at the level of the illuminate. The limitation for post-type A dissection are the anchorage zone in the ascending. So repeat to your CT surgeon to think, even at night, to keep you 4 millimeter length, the ascending of more than 38 millimeter, and iliac excess too small. So in conclusion, 3-branch arch repair is our best option for patients of more than 65 years old with a previous type A repair. A total percutaneous access is our standard technique. 4 centimeter sealing zone less than 40 millimeter diameter is necessary. And now left common carotid and left subclavian artery retrograde branched design is our current technique. Thank you and muchas gracias.
Thank you very much, Dr. Faure. Next speaker, Dr. Ferri from Torino, Italy, will tell us about the Nahuta endovascular graft for the aortic arch.
Thank you once again, Manuel, for the invitation. So first, just a short reminder about this endograft. All Nahuta endografts have composed by 5 stainless steel stents covered by a PTFE fabric sutured only on the edge of the endograft. And select fenestrations depend, obviously, on vessel morphology. To answer to the question, what we can do with this endograft? We can treat obvious penetrating atherosclerotic ulcer of the arch. In this case, total endovascular repair can be achieved easily. But we can also treat aneurysm of the arch in a distal arch and a post-dissection aneurysm, and we can fix type 1 endoleak after TEVAR procedure. The fenestration is inside the sheet are pre-oriented, so we have not to rotate the device during navigation, and the device is pre-curved. It's pre-curved because it's compared to the anatomy of the arch that can be treated. And simulation test assure accurate orientation and vessel patency. The inclusion criteria are very important. Prox neck more than 20 millimeters, distal neck 20 millimeters, ascending aorta diameter not more 38 millimeters, so the descending aorta diameter not more 38 millimeters. But if you look at this image and compare the standard tube endograft and fenestrated endograft, you can see that we can increase proximal landing zone and improve proximal sealing to maintain perfusion on the supraortic vessels, avoiding obviously the branching or chimney. Here our experience, the technical success was very high, about 98%, with only one case of type 1 endoleak. Right stroke rate was very low, 4%, 3 cases and 2 were minor stroke, and no retrograde dissection was not reported. Often, extra-anatomical revascularization is required. In our experience, you can see that one vessel was revascularized in 10 cases, 2 vessels in 47, and 3 vessels in 19 cases. Many centers prefer procedural stage procedures. You can see that about 60% of centers perform stage procedures. Left carotid to subclavian bypass was performed in 60% of patients. 10% of patients underwent carotid and carotid subclavian bypass. So this is a deployment of the endograft. Is completely different from the standard endograft. We can use, it's mandatory to use a 4-meter hydrophilic guide wire from humeral artery to the groin. During navigation in the aorta, guide wire should be pulled from both sides to achieve navigation. Remember that the device is procured, so it could be dangerous during navigation. When the tip of the endograft is close to the innominator artery, pushing the guide wire from both sides, you can create a loop, and then you can achieve navigation in the correct position. Pacing is not required. Blood pressure about 80 millimeters of mercury is good. It's a good pressure, and deployment should be done very carefully. It's important to maintain a loop inside the ascending aorta to avoid the migration of the graft, and pull out the tip should be performed very carefully to avoiding migration of the graft. So you can see the final check. In this case, 2 vessels were revascularized before procedure. It is very important to consider the stroke rate when we talk about the endovascular procedure on the arch. We know that use of branch devices are affected by a high rate of major stroke. Using fenestrated endograft, we can obtain results better than branch. But if you look at this paper, we can see that a lot of patients treated by branched devices can be treated by fenestrated devices, so lower risk of stroke. So we have to consider, when we planned cases, the use of the fenestrated devices. Obviously, it's not a complete endovascular procedure, but it requires surgery to revascularize supraortic vessels. Last, was published this paper concerning the arch repair to treat the residual type A dissection. And you can see that if you consider the CT scan of this cohort of patients, Nayuta has the highest anatomical applicability. So, dear colleague, when you face the pathologies of the arch, consider this endograft for your procedures. Thank you.
Thank you very much, Dr. Ferri. And our last speaker will be...
Yeah, excuse me. There is a little modification in the program, and perhaps we can have online Professor Wei Gou from Beijing. He, even though the G branch, of course, is not a device for the arch, but he has a special concept and new devices also for the arch. So we take the opportunity. He addressed a presentation about the G branch and other devices for the arch. Thank you. Professor Wei Gou, are you available?
Hello, Chair. Can you hear me?
Yeah, thank you. You can start your presentation.
Can you see my screen?
Yes, fine.
Okay. Thank you, Chair. Distinguished honor for me to have opportunity to introduce about our works. And I'm Dr. Guo from the Department of Vascular Surgery, PRA General Hospital, Beijing. And this is my disclosure. During the last decades, we tried to develop a few numbers of the new devices, not only the arch branch, the reconstruction endovascularly, but also the interpatch and intercell for the precise repairs of the dissection into tear. And over 16 clinical studies we are working, and about the thoracic abdominal aortic aneurysms, the story from the renal visceral artery reconstruction, not only the TAAA and the thoracic aortic abdominal aortic dissection, but also the juxtarenal or pararenal juxta SMA aneurysm with a terrible angulations for this kind of pathologies is impossible to use the fallustration and T-branch devices for feet. And we need our off-the-shelf one device for the feet or anatomy, I think. So we develop our T-branch stain graft. T-branch stain graft contain double inner branch with 10 mm diameter and two double outer branches in 7 mm in diameter. And the two prolonged together where is very convenient for operator to establish the track to reconstruct the aesthetic track and SMA. And the semi-release designs make it easier to adjust the position of the main body stain graft. And the flexibility is very important because of our favorable flexibility is very important for aorta angulation. And we also developed the silver floor bridge stain, curved stain, that stain is covered by BEP-LVE. And a total number of 26 types of T-branch in the graft are available for use. So this device can be used in emergency operation. The procedure is easier and safer. And after deployment of the proximal part, and use the snare capture the prolonged wire, and then establish the track, and then to reconstruct the celiac tract and SMA, and then to reconstruct bilateral renal arteries. And about tips and tricks, for example, the first one, initial ever significantly affected re-intervention plan. Sometimes we have to use the distal aorta extension combined with the T-branch main body. And sometimes we have to use the distal bifurcated stain graft if there is no enough length of the distal landing zone. And some cases very difficult. For example, this guy, he accepted first TVAR because of the diagonal TVA, and the second operation is TVAR, and the third one is embolization because of the type 1 anal leak. And the fourth time the patient got to our hospital, we have to use the G-branch to reconstruct the celiac tract, SMA, and have to reline the double chimney cover stain. And the second one about the tortuosity factor, the first angulation almost located at the descendants of the aorta about the celiac tract. For this kind of pathology, I prefer to use the general thoracic stain graft first, and then use the T-branch distal. And if the tortuous aorta located at the proximal landing is significantly influence on main body positioning, is only one time to position your main body, so must be carefully. It's impossible to adjust after deployment, even if in semi-release. And this tortuous abdominal aorta sometimes located at the renal vessel with a very small space. For this kind of pathology, we must concern about the branch cover stands long patency, so we must find a bigger space for the renal arteries cover stand. We use the crossover technique from one side to other side. And so the follow-up CT, we can see the double renal cover stands located at posterior of the main body because of the bigger space of beyond after the post of the main body. And access the renal arteries is the problem. Sometimes we have to sacrifice the smaller renal artery. The diameter is smaller than 3 mm. And the fourth one is the multiple degeneration aorta. We have to stage repair, but we must constrain to reconstruct the internal artery to avoid the spinal ischemia complications. The renal artery angulation is very popular. Sometimes the renal arteries came from the aorta and go up, and we used intersect bilateral renal artery graft with each other. This is one kind of method. And sometimes this product looks difficult, but it's easy because of the both renal artery originating from the normal aorta. The vessel wall other side give enough support to your delivery system, so it's not difficult. But another kind of condition, this one, renal artery from the sac of aneurysm is very difficult. We have to use the snare right technique. We use the sheath and the catheter, snare capture the wire through the left branchial, and then give us support to deliver give us support to the delivery system, and then to reconstruct the renal. Dissection is a problem. Sometimes the branch vessel originates from the fourth lumen totally, and the original orifice of the branch vessel occluded. So for this condition, we have to puncture intimer through a steerable sheath guide, and then dilatation using a smaller balloon, and then to a bigger balloon to stimulate the trail to the right kidney, right renal artery, and then to put in a bridge stay. And here is the follow-up. And aortic morphology affect ventral artery reconstruction, especially type 3 arch or right-sided descending circle aorta. For this kind of the morphology, the through and through wire is very important, because the wire gives the sheath enough support, make the sheath very stable, and the sheath give us support to your delivery system. And the evidence of the G branch from the first image study, and at the beginning we just enrolled 15 cases in our first image study, but we obtained our excellent results, not only sort of abdominal aortic aneurysm, but the jactrenal or pararenal. Here is the follow-up result. 12 months, no inner leak, no paraplegia, no branch artery stenosis and occlusion, but one patient died of the acute cerebral infarction. And then we started the journey of the G branch evidence-based medicine. The Guarantee 1 study is the prospective multi-center sample size 73, and the Guarantee 2 is prospective single center, just in my center. And the GUARD study is just focused on the thoracic abdominal aorta dissection. Here is the Guarantee 1, and we started these studies for 3 years ago, and we have finished the enrollment, and will follow up, continue for 5 years post procedure. Here's baseline information about the GUARD 1 study, and over 90% cases, the AIC score from 2 to 3, and about 56% cases with the type 4 aneurysm, of course, including the jactrenal, pararenal. And the procedure result, the average operating time about 300 minutes, contrast but over 200, technical success in all of the cases, but 3. One type 1A endoleak, one type 3 endoleak, one left renal artery occlusion. But this, for every other centers, the operators, it is all of the cases only belong to the learning curve case. And this picture shows the follow-up data. 30 days result of major adverse events in 4 cases, no all-cause mortality in this cohort. 12 months follow-up, 1 patient died, and 2 patients type 1 and 3 endoleak. Endoleak reached 2.9% 1 year later, and 7.6% renal ventral artery patency. Because of this section, just focus on arch pathology, So I want to introduce a little bit information about our experience. At this position, we also developed the V-flow T branch, V-flow bi branch, and V-flow tri branch. And the T branch, the product has obtained the registry from the NMPA. And V-flow bi branch, we have finished the multiple center clinical study. And the V-flow tri branch, this one, the structure. The first segment is the double inner branch, and another one is the retrograde stained graft crotch arch. And we are working the multiple center clinical study for this device. And combine the with the tri branch and the G branch, we realized the total aorta repair endovascularity. So in conclusions, the evidence of the guarantee and the guard studies indicated the safety and efficacy of the G branch stent graft for thoracoabdominal aortic aneurysms and complicated AAA. And the evidence that G branch seems to be suitable for variety of areas with the challenging anatomy, but the limitation from the indispensable for axillary or branchial artery approach and utilization for pathology with narrow lumen at a renal artery level remains of concern, especially in Chinese patients, sometimes very small space of the aorta. Thank you so much. Thank you for your attention.
Thank you, Professor Wei. Congratulations for your excellent result at short term. There is any question on the floor? No. During this short follow-up, have you noticed an increase in sac diameter in some of these patients?
I can't hear you.
Sorry, can you understand the question? Have you observed any increase in diameter in some of these patients? During
the criteria of the diameter, right?
Sorry?
You mean diameters of the aneurysm?
Sac enlargement, I mean. Have you noticed in some of your cases increasing diameter of the aneurysm during this short follow-up or not?
I can't understand your question.
Perhaps I rephrase. Is there any sac enlargement in your patients with the G branch or not?
No.
Not. Well,
yeah.
Another issue, what is the rate of type 2 endoleaks in this series? Have you... Type 2 endoleaks, what about that?
Yeah, the type 2 endoleak is very rare in our study, clinical study, because of most number of the animals with enlarged thrombosis. His inferior medullary artery and limb artery is occluded already.
Okay, so any question in the floor? No. So thanks for all, Professor Wegu. Thank you. Thanks a lot.
Thank you.
And now Dr. Alonso will tell us about their experience with their endovascular approach to ARC pathology.
Well, I'm going to talk shortly because it's late, we are tired, and about our management of aortic arch pathology. Patients are from other peripheral regional hospitals and also some national tertiary hospitals, and are referred to cardiac or vascular surgery, and cases are evaluated by vascular surgeons, cardiac surgeons, or an anesthesiologist. So at the moment, patients, we are aware of the good results of open repair for the arch. So in those patients with good risk, with a standard risk, conventional surgery is indicated. If the patient is a high-risk patient and life expectancy is shorter than 2 years, usually the patient is under medical treatment. If the life expectancy can be more than 2 years, then an endovascular procedure can be approached. In emergency cases, the branching or a mixed technique or a fenestration usually and can be performed, and if the patient can wait and the anatomy is adequate for a fenestration or branch endografts, then we perform these techniques. Branch endografts are usually performed in patients with with proximal arch pathologies, and fenestrations are used mainly for more distal arch pathologies. In this experience, we have a short experience with a single branch for the subclavian, so probably many of the patients with fenestrations are nowadays treated with a branch for the subclavian, an only branch. Our experience with thoracic grafts comes mainly from the Relay platform, and we are using the dual or triple branch inner branch platform for the arch. We are in favor of open exposure of the carotid with a small incision and cross-clamping of the carotid with an antegrade deployment of the branches, rapid pacing through the Landerquist, and these are our results in 12 patients, our first initial experience. 8% stroke rate and perioperative death. This patient died after acute myocardial infarction and stenting, intracranial bleeding, and death, finally. We prefer also always to treat with more branches, in my opinion, less problems for the patients. This is a case of triple branch, and as it has already been mentioned here, the problem is that just probably half of the patients are inadequate for a branch endograft with Cook or Aortic platforms at the moment. So in some cases, when we need a single branch in a patient that allows for waiting, we, in these cases, we use a single branch. In this case, the Gore device is my preference. It's very easy to use and with good results in these cases, very easy, and with few problems compared with fenestrations at the arch where the orientation can be an issue. With this device is really easy. If we have an emergency, the scenario is different, and we cover the subclavian or perform, whenever is possible, fenestration. Initially, with this foot-through needle, we perform some complex cases like this one, triple fenestration of the arch with an extensive covering from the sinotubular junction and to the proximal descending thoracic aorta. And nowadays we are performing these procedures with an electrified guide wire that is much easier than with the needle indeed. So this is also very easy. And this is one of the cases, mainly for the subclavian, with excellent results. Of course, we have not forget the extrathoracic debranching or intrathoracic debranching, because even in nowadays they can be a nice tool. Just a comment regarding intrathoracic debranching. In my opinion, it's better to use a small diameter tube in the ascending. 10 millimeters is enough, and from this tube we take off branches or tube for the left subclavian and the brachiocephalic and the left carotid. This is an example of a patient with a bifurcated graft in the ascending and occlusion of the left branch for the left carotid. And finally, it was treated with a subclavian bypass with reimplantation of the common carotid in this graft. The follow-up is the standard follow-up for these patients. So this is our approach to these complex cases. I think that we need to have several techniques in our armamentarium to treat these challenging cases. Thank you.
Thank you, Dr. Alonso. I think we have time for a few questions.
Yeah, for sure.
Is there any question in the audience? I have one question that could be answered maybe by Dr. Fabre, but also by the rest of the panel. We have several devices for endovascular repair of the aortic arc after a type A chronic dissection with promising results. Do you think that we could be less aggressive when we operate a patient with an acute type A dissection and perform less frozen elephant trunk and just changing the ascending aorta?
Thank you for your question. I think the good results that I presented were for type A dissection, and we selected. You can see that there is really a difference between arch aneurysm with shaggy aortas and so on compared to patients with a previous repair. Indeed, the level of stroke is very low. But regard to your question, I think we don't have any experience with other devices. Our experience is limited to the Cook device, and we used to do some laser fenestration or guide wire fenestration for the left subclavian artery, and I think the results are quite good for that. But indeed, it's a limited experience, and I think to improve the level of stroke, I think working with only one reference huge center will improve your results. We know that when you do a frozen elephant trunk after a previous repair, the level of stroke and mortality is around 20%. So it's a huge level. So you have to discuss with the CT surgeon, and looking at Stéphane Rolland's publication, we saw that the results are quite good. So indeed, there is a place for endo, not to do a new open approach. You have to discuss with the results. The results are good, but I think you have to do a lot of cases to have this kind of result, because at the beginning, I think the first patient, only the 10 first patient had some strokes, and after now, we don't have any more. I cross my finger, but we'll see in the future.
Talking about that, do you use any prevention of stroke system while deploying an endograft?
As Thilo Kolbeld published before, we use some CO2 to flush the graft. And we don't use anymore any clamping because we do a total percutaneous approach. So we don't use any filters, any kind of protection like this. We have only a NIRS, and usually the time for the graft deployment is very short. As you can see, the time of operation is short, and I think the level of stroke is maybe related to that.
Any question?
So talking about prior type A repair, I think that the theme of discussion with the cardiac surgeon should begin at the right moment of the type A repair, because we see many patients that develop distal arch aneurysm due to the chronic dissection, and that cannot be treated with an aortic arch endograft because the ascending repair is too short, or there is a kink at the level of the ascending aorta. So probably that's something that the cardiac surgeon should keep in mind in a dissection that has a distal extension. And then I have a question to the whole panel. Probably a good ascending surgical graft is a good landing zone for an aortic arch endograft. But what we've seen in our practice is that there is some risk of endoleak, of a type 1A endoleak, especially if you do the CTA control in the early days after the operation. And usually then these spontaneously resolve. Is it something that you noticed as well?
We have done, I think, 90 aortic arch, and we have 3 patients with a type 1A endoleak. And one was treated with embolization without success, and the 2 other ones have still a type 1A endoleak. So yes, indeed, it's an issue. Actually, no mortality, but it's really an issue. And I think we didn't really agree regards to the level of angulation, because usually when there is a previous repair, sometimes there is a 90-degree angulation in between the ascending and the arch. And now with only one sealing stent, you can really have a nice fit to the previous graft. So now for us, it's not really a limitation to have a huge up to 90-degree angulation in the ascending.
In our experience with the Nexus endograft, we saw one intraoperative endoleak type 1A. Maybe this was the reason, because the measures on the previous angio-CT and the traction of the ascending aorta was not good. We successfully treated inside the same intervention with another ascending model. But I think the preoperative schematic and the study based on only in CT in several cases is not good. Maybe the gathering, you have to perform maybe an angio-CT gathering with electrocardiography. It could be a good tool to perform these cases.
Well, Enrique, I have firstly congratulations for this work, and results really are disappointing. You know, perhaps learning curve has an important impact in the results. So probably centralization of these patients for endovascular treatment of the arch is mandatory from my point of view, because it seems a very easy technique, but fairly you must have adequate imaging, you need experience. So what is your opinion? And from foreign speakers, what is your
First of all, I think the 20% of mortality after 1 year in this kind of patients, I think is good, because these patients, previous the intervention has been evaluated by the aortic team, and all of them were not candidated to open surgery. So the other option was only medical treatment. So maybe these patients we have 1%.
Mainly with the rumor device.
Yeah. We see there are lots of centers, maybe in my opinion, there are too much centers to perform these cases. Because this was a real world study, because several of them performed their first or second case of the repair of the aortic arch. So I think that I totally agree with the learning curve could be longer to perform this type of cases. Now in Spain, I think it is a problem, because nowadays we have 70 little countries with totally separate healthcare for the patients. I think totally agree with the centralization of this type of patients. Of course, maybe with our colleagues from France, I think it's the better, because they have all experience to perform these several cases, and they can approve these patients and can perform these heavy complex cases with good results. Nowadays in Spain, we are 70 little countries with totally separated healthcare of our patients, maybe we need to referral centers, of course, totally agree.
To answer to this remark, I think we are lucky in France to have a reference center, but the limitation did not come from the physicians, it comes from the company. It comes from the companies that to have nice results, they limited the use of those grafts to only few centers to improve the results. So I think it's not only to the physician, but also to the company to publish better results and to be involved in our activity. They should limit to reference center or centers that they find good to produce nice results. And it was a limitation in our country. Not the physician, but companies.
Okay. Any other question? Michelangelo, I would like you comment about what patients nowadays are adequate for Najutta, because it seems that the number of cases treated with Najutta decrease in number. Is that true? Probably because there are new devices. This is an old device in Japan, in Asia, but not in Europe, and the new devices with a single branch for the subclavian, for example, can be an issue.
Yes, absolutely. So I think there's like a run to use a branch endografts. But I remember to all of you, that the stroke rate is still high. Sometimes we treat relatively young patient with post-exchange type A dissection with a total endovascular procedure. Why not perform a hybrid procedure, like a Toraflex or Evita? I think also that fenestrated devices have a very low stroke rate, and we have skillness in performing surgery. So what is the problem to perform a carotid subclavian bypass and then covered subclavian, or car subclavian bypass? And also stroke rate is lower because we are skillness to perform that kind of operations. So I prefer, when possible, to use fenestrated devices because stroke rate is lower if compared to branched device.
And I think that we have 5 minutes yet. I would like to pose a question to Jacobo. Do you think that this new classification could change the way we approach these patients, or things doesn't change?
This classification changed the strategy to treat our patients. Mainly, it's the first time that the difference between urgent and emergency surgery in type A and non-A, non-B dissection. And it's the first time that the treatment must be orientated not only by the localization of the main entry, but to the malperfusion situation. So it's the very critical ill state may change the indication, emergent, urgent, total replacement, or only the hemiarch procedure. We'll change our way to treat patients with dissection.
Have you any question? Okay. So, and the last one, because you can't leave here the podium without a question, of course, Francesco. From on your clinical practice, how you decide which endograft for a patient? I mean, between Cook, for example, and the relay from the room aortic, because both are quite similar.
I agree that they are quite similar endografts, and I must disclose that our experience is mostly with the aortic endograft. And one difference may be the size of the ascending aorta, because with the terumo we can go up to 43 millimeters, with Cook is restricted up to 38, and this is probably the main reason. Then also there are some cases where, due to angulation of the aortic arch, you have a moderate, I would say, risk of misalignment of the diamond-shaped outlets of the Cook endograft. On the other side, with the terumo, you have a large common outlet for the two tunnels, so in those cases we prefer the use of terumo. But of course, that's also related to our greater experience with that type of endograft.
Okay, thank you. Any question from the audience? Not? Well, I promise this is the last one. And this is to Dominique Fabre. You comment on flushing with CO2, decreasing neurological complications, and so. How, from a practical point of view, how do you perform this flushing?
You mean the flushing with the CO2?
Yeah.
Also, we have a bottle of CO2.
And you perform flushing with CO2
First we flush with saline, with a lot of syringe, maybe 3 or 4. And then we put the CO2 directly inside the sheath of the graft, and stay for 5 minutes maybe with this flow inside the graft. And after we deliver the graft.
Deploy it.
Yes.
Because perhaps I misunderstood, but Tilo Colbert performs a quite different technique, performs flushing with CO2 and after that with saline. Is that true? I read it in a paper. I had never seen it from him.
We published the paper together, so maybe I'm wrong, but in our current practice, first saline, then CO2.
Yeah, because yes. This is because I have already read this in a paper, and it's much more reasonable to perform the procedure like you described, of course.
And I think the last point regarding the level of stroke is also the fusion imaging that is really an advantage, and maybe in few centers where they do only 1 or 2 cases, they don't have access to fusion imaging and those nice hybrid rooms, and maybe it's a reason to have higher level of stroke.
And also, when we are talking about a stroke during endovascular procedures at the arch, an interesting point is that the incidence of a stroke depends on the definition of a stroke. And this is a very important issue. We know this comment from TAVI procedure, for example, and the range of stroke is from 0.5 to 80%. So it's an issue to take into account.
Indeed.
So I think that we are ready to close this symposium. I think that Jacobo could address some words to the audience. Te diriges.
Thank you very much, all of you, for coming here to Oviedo. Asturias is not an easy place to reach because of the mountains. So we keep on mind when we organize this course that we work together. As I said in my presentation, aorta pathology is not only a stunk pathology. We have to treat and study all the aorta. So this is our philosophy, and will continue to improve the symposium.
Well, so thank you all for making this event possible. Thank you to Cardiva once more, and I hope to see you in 2026 with a new CASO edition. Thank you.